today with you on data quality and its impact on healthcare outcomes. I'm joined today by thought leaders from Innovaccer and from Wolters Kluwer. We've recently joined hands for a collaboration to improve data quality. And we'll be talking to our speakers today about why this collaboration makes sense for a digital health platform like Innovaccer and a terminology services platform from Wolters Kluwer, Health Language. Joining me today are thought leaders from both organizations that bring interesting and unique perspectives to solving this problem, or at least getting closer to solving the problem. Anne Donovan is the general manager at Health Language, Wolters Kluwer, and brings us the business perspective on improving data quality. Brian LeBerge is a solution engineer and a clinical informaticist at Health Language. Mike Sutton is the Chief Technology Officer at Innovaccer and has many years of experience in leading large enterprise information technology teams in solving this data quality conundrum, both in the healthcare and the non-healthcare domain. Welcome. I look forward to our conversation. So let's start our conversation by getting to know Mrs. Harrington a little better. Mrs. Harrington, who looks a little older than 63 years, I would say. Maybe life's been hard on Mrs. Harrington, and we'll find out why. Well, unfortunately, she's had a series of healthcare problems. She has had a history of moderate COPD, accompanied by obesity and hypertension, lived the wild life and been a smoker all her life. Unfortunately, with her healthcare provider giving her a strict admonition and wanting her to quit about 2 years back. She's been complaining of shortness of breath and fatigue and on exertion. About a month ago, Katie Harrington woke up in the middle of the night. She wasn't able to breathe. She had a persistent cough, lots of congestion in the chest, called up her daughter, showed up at the ED, went to an affiliate hospital, was admitted there for a couple of days, and unfortunately walked away with an additional diagnosis of heart failure along with her COPD. This is her second follow-up visit with her primary care provider post-discharge. Now, Katie Harrington's story is not unique. Any of us who's had the unfortunate chance of having multiple comorbidities, multiple diseases, has probably had a similar experience interacting with the healthcare system. Our patient care data is unfortunately fragmented among many EHR systems that are a function of the providers that we see, whether they are primary care providers or specialists. Weaving that story together that we saw of Katie Harrington requires providers to access multiple EHR systems, maybe even multiple claims files, pinging the HIE to find out recent vaccinations. And even when all of this information is brought together, it's in a variety of formats: HL7V2 messages, CCDAs, flat files that are in XML format. I would not be far to say it's every clinical informaticist's dream or nightmare, whatever way you want to look at it. But the complexity rises further, because even when you're able to bring all of this information in one place, it's represented in different terminologies, different standards. We can have diagnoses that are represented as ICD-10 codes or SNOMED codes. We can have a med history that's represented using RxNorm codes or NDCs or free text. We can have a large portion of Mrs. Harrington's story written out as a conversation, as a progress note that the provider captures interesting insights. For example, a very important marker, such as an ejection fraction, which led to the diagnosis of her heart failure, is captured in the unstructured portion of her EHR. I'd like to take a pause and ask, my esteemed speakers what they think about this complexity. And any thoughts?
Sure. Thanks, Shobha. When I think about how I came into healthcare, I talk about the formative years of my career that I spent in financial services working for Capital One. And if you think about the world of financial data, and you think about creating the picture of someone like Mrs. Harrington, you think about this idea of credit score. And we can all kind of get our head around something like a credit score. We have a pretty good understanding of things that we do that contribute to what that credit score is. And we understand how that is typically used to assess our credit risk. Well, in the world of healthcare, even the standard data is complex. And just like Shobha said, when you're pulling all of that information in from so many different sources, from different terminologies, different languages that people use, the language of a clinician that they use to describe the risk of a patient is different than the language that's used on a claim to describe what it was that the physician saw or did to the patient. And so when you think about having to pull that together and what that means, you get this picture of just how difficult it is to paint that picture of a Mrs. Harrington. So let's start with even the standard data that's hard. I like to take a problem that seems simple, something that you would naturally be able to understand wanting to study. An example, like I want to understand the impact of medication on A1C on my population who has diabetes. Why might you want to do that? Well, I might want to do it because I might want to see if different medications work differently. I might want to see if I'm running a care management program, if that's an effective form of therapy. I might be looking to reduce costs, and I might want to think differently about how different drugs cost different amounts and maybe drive the same outcomes. So, okay, I can get my head around something like that. So let's take diabetes. What's so hard about diabetes? That's an easy thing. Well, there's actually 570 different representations in ICD-10 of diabetes. So are you talking type 1 diabetes, type 2 diabetes, type 2 diabetes, gestational, non-gestational? And so the whole idea is that as you think about even a simple problem and standard data, there's a world of complexity, even in standard data within healthcare. So moving along that continuum, about, again, something that seems simple, A1C. Brian, what do you think?
Yeah, it's funny on that data because while you have the standardized ICD-10 that are known, when we get to A1C, while that's structured text, it isn't necessarily standardized. And so it's really trying to find a needle in a haystack of what was the term that was actually used to say this was an A1C test. And with actual data that we've had for a particular client, there was actually 247 different ways that an A1C test was being represented, even though if you look at the industry data, there's like 9 standard codes that should be used for that. And so it's really that complexity. Finding that needle in the haystack is hard. And if you thought the diagnosis was hard on that side, Anne, wait till we get over to the drugs, where these NDCs are national drug codes, and those are specific to kind of the packaging and the quantity of drugs that are in it, so not just the drug itself. And so as we wanted to look at, say, a drug that's used to treat diabetes, well, one drug class itself, there's over 4,000, almost 4,400 ways that particular code could come in that represents one of those medications. And we pulled this number, I think, about 2 weeks ago as we were prepping. Medications change daily, so that number is probably closer to 4,400 now than what it is today. And so it's really challenging with even this structured data to be able to find what you're looking for and make sure that you're answering that really simple problem statement that you laid out for it. And Shobha, I know you see this on probably a daily basis as well as you guys are working with the data.
We do, and this is why we are so lucky to have, joined hands with you guys. I mean, we're talking about one simple lab here that's represented in 247 different ways. Would love to talk to you about, as we go into this conversation about how do you make sense of that? How do you actually help us normalize all of that information so that we can report on better outcomes for our customers? That's really the goal of the conversation today. So stay tuned, and you'll hear more from all of us in terms of how we are getting closer to solving that problem. Before we go any further, we wanted to get a pulse check on the audience. And I know we are all interested in data quality and how it impacts outcomes, but scan the QR code here. It'll give us a sense of who you are and what kinds of outcomes are you struggling with at your organization because of lack of data quality. And we'll wait for the results to come in. I know there's many more of you than the 2 or 6 that are typing, so please whip out those phones and scan the QR code and let us know your thoughts. This is going to be an interactive conversation. We see poor data source for AI, sepsis, poor reporting, not interoperable, referrals, network integrity, care coordination. Certainly, a lot of, as one of the outcomes of value-based care, you want to make sure care coordination, referral management, all of these outcomes that rely so heavily on data quality are served appropriately. Patient understanding, DDIs, open gaps in care. Wow, this is certainly a very rich set of outcomes that our audience is thinking about. So thank you for that. Appreciate the participation. I think a lot of you talked about these outcomes, but I wanted to go back to this seminal report that Gartner produced maybe 3 years back. 2021 was when this came out. And it talked about a whole spectrum of healthcare outcomes that were impacted by poor healthcare data quality. Everything from the individual patient receiving subpar treatments, whether it's under treatment or over treatment, providers being unable to make appropriate clinical decisions because they just didn't have the entire picture of the patient who was in front of them. Or all the way to a societal impact where the lack of data fidelity contributes to impeding our ability to do drug development or produce the innovative therapies of tomorrow. So huge impact, lots of outcomes, and we've certainly seen some of those come in the outcomes that you represented to us. Huge financial burden as well. I'm sure most of you are familiar with some of the numbers that we hear about in terms of wasteful spending. $765 billion is what the IOM quantified this as, and that was, I think, over a decade ago. Just to put that in perspective, that means every dollar that's spent in healthcare, 30 cents of that can be labeled as wasteful spending. So certainly lots of impact here in terms of poor data quality and what it means for clinical, financial, and societal outcomes that we're going after. When we think of data quality, as an industry, there are 6 dimensions that are commonly referred to as the pillars of data quality. That said, our leaders in our organization have a unique perspective in how we think about data quality at Innovaccer and at Wolters Kluwer. Mike, tell us about how you're thinking about data quality and what's Innovaccer's perspective on this.
Yeah, thanks, Shobha. And before they do that, I want to talk a little bit about that cost element of, this data quality, lack of data quality causes a lot of extra spend in the IT departments. You know, when we look at and characterize large data environments, there's four main attributes we talk about, and one's volume of data. And you know, the good news is the advent of the cloud has brought on affordable ability to go after the huge volumes. We used to have to buy special purpose hardware, special purpose equipment to handle the vast volumes that the clinicians wanted to use and the data scientists wanted to use. And that's kind of being solved. And then we have this area of the second V is velocity. We have to get the results, the analytics in the hands of the decision makers as soon as we could. That's also being solved kind of with the cloud, advent of the cloud and all the streaming services that are available. The third one, I'm putting these in orders of kind of where I think we're climbing this mountain is, and you already mentioned some of this, the variety of data. I think Brian mentioned it as well. Now, we still have a huge variety of different EMRs, different source systems to translate all that information. But, you know, there's a goalpost out there that looks like there's some common standards that we're merging to, and that's getting better and better. Certainly not a done problem. But then the last one, and the one I've always called veracity, to me is the translation of data quality. If you look at the dictionary, veracity is called devotion to truth. I think that's a perfect definition of where we want to get to. And then we at Innovaccer, as we kind of had this, maybe not the last frontier, but the next frontier, enabled to curate the data. Because what happens when we don't get data that's trustworthy or of high quality, what do the data scientists and analysts do? They go create their own data pipelines, because they can trust when they have done that level of curation themselves. But that just creates more and more costs and more repetition in the environment, you know, in this data environment. And what's kind of ironic is it's probably one of the predominant costs, but it is so hidden in these IT organizations. It's hard to, you know, the CFO may or may not know, you know, what part of how much cost it's actually driving. So then we get to these points here about data quality. I won't certainly go through all these. Certainly mention timeliness as an attribute of velocity, data completeness. When I came to the healthcare business, it was interesting to me that we didn't really do a great amount of understanding the data we had. And we used to call it data profiling. Now we're calling it data observability. But do we know as a health system or a payer or a life science company do we know what the quality of the data is that's operating on our, you know, making decisions in analytic environments? That's what data observability and where we want to get with some of these factors here in data quality. And, you know, and certainly Innovaccer is probably one of our biggest areas of research and development.
Yeah, love the 4 V's, Mike: volume, velocity, variety, and veracity. You captured that really nicely. And what's your perspective? What's Health Language's perspective on data quality?
Thanks, Shobha. Yeah, one of the reasons I think we made great partners is you have a very broad view of all of the elements and the aspects of data. And I would say within Health Language, we have a very specific focus really on words that I didn't quite know what they meant actually when I joined, which is this notion of semantic interoperability. And this, you know, for me, what that word means is much like what Mike talks about with veracity. It's, does the data have the truth in meaning that it was intended to have? And so if you look back at Health Language and who we are, we were founded by clinicians over 15 years ago who had a vision of interoperability before it was a word that was used in healthcare. They really wanted to look at all of the different components of data that existed within the healthcare ecosystem and make them accessible, because they, unlike I 15 years ago, didn't recognize how the language that clinicians use when they use something like SNOMED to describe the clinical attributes of a patient are different than the language of ICD-10, which may end up as what's on the claim in terms of defining that same condition of a patient. And so when we think of data quality, we think of that word semantic interoperability. How do we take all of the data from all of those terminologies out there that are the languages that clinicians use, that payers use, that EHRs use. How do we take the different vast languages that exist in this healthcare ecosystem and bring them together in a way that can be packaged and easily managed and maintained? And to do that, we need to be experts in that. We need to know that there's 130 different websites that we need to monitor and maintain in order to keep track of these terminologies that can be updated. And so that's the first step in our process. Then we need to bring those updates in. We have a team of clinicians that validate those. We will actually go out to these governing bodies and say, hey, we think you got something wrong with this update that you just did. Can we have some dialogue? And then we model that in a way that makes it easily accessible. So when you think about, does my data have the true meaning that it's meant to have, especially when these terminologies, and you can see here on the slide, are being updated as often as they are. And then we're able to, through our process, deliver that to our client so that you can have that trust that that data has the veracity, has the meaning that you need at that most foundational clinical level in order to then derive the outcomes that you're looking to derive. So
And
how's that for
certainly-
data quality?
Yes, absolutely. And then this was certainly very important to us as we looked across, trying to choose the right partner to bring on board to make sense of the clinical data. We certainly saw that because of the strong foundation that Health Language has that you mentioned in terms of clinical expertise, subject matter experts who look at this problem from a clinical lens. That's the collaborative spirit that we really wanted to bring because and we'll talk a little bit more about this, we're very good at bringing the data, putting it in one place, making sense of it syntactically. And then for the semantics, in terms of the reference data, in terms of the semantic interoperability piece, we really needed a solid partner in order to be able to help us on that journey. So certainly look forward to more as we form this collaboration. Thanks for shedding some light on that. You've talked about, how your clinical experts basically make sense of a lot of the semantic interoperability pieces, how your algorithm works in order to look across categories and make sense of the data. I think one problem in the industry is you can have all of these pillars, you can think about completeness, conformity, consistency, make sure that the intention is captured, timeliness and accuracy. But at the end of the day, you want to make sure that you're measuring these components. And we certainly at Innovaccer, we've had multiple initiatives where, we want to look at this from a variety of lenses, whether it's bringing better transparency and observability to our customers, or really delving deep into the data and making sure that the clinical context or the intention of what we are capturing is auditable, is transparent. Mike, did you want to speak to some of these initiatives that we've been working on?
Sure. Sorry about that. My phone overheated down here in the Florida sun. So
Oh boy.
but happily we have a reboot. So yeah, so so the big thing kind of happened in this area now, if you take the broad term of data management, data quality, is very specifically, there's a lot of tools and capabilities that are becoming available. Just like the cloud helped us solve the volume problems and the streaming services helped us do the velocity problems. There's a lot of capabilities out there that are helping us with the profiling of this information and doing data observability. And I know when Ann was talking, I was thinking we wanted, I think we need to help people understand that we have a data supply chain from raw data to refined, curated, actionable data. And the great part with our partnership with the Wolters Kluwer folks is we're doing that semantic interpretation of that data at every step of the process. So there's actually 6 steps in the process. We're certainly not going to get into the detail for that now, but the data is measured and observed for its improvement in quality and understandability at each one of those steps in the process. And probably one of the most recent things that we've done is because we do operate, solely in the clinical space and the claims environments, and acquire just on the file acquisition side, we know exactly what to expect from a payer, what exactly to expect from one of the EMRs, what the files should look like, how many blanks is acceptable, is understandable. And that whole category is kind of this big push for observing that data, and then we can actually track its progress as it matures during in that data supply chain.
Yeah, for sure. I loved what you said about, going from raw to refined data. And maybe I'll bring it home a little bit in terms of, what we do, taking raw data from a variety of sources and applying, as Mike was saying, a variety of business as well as logical rules that allow us to optimize the process in terms of taking that raw data, syntactically and semantically mapping it so that we can create a unified data model. A lot of engineering expertise goes into the syntactic mapping piece. We have auto mapping rules that, as Mike was mentioning, understand, given a particular format, given a particular source, what types of data can we expect. That second layer, though, the semantic mapping piece, is where we think about this collaboration, because that's where we are making sense of the data, whether it's making sense of it in terms of standard terminologies. It's a diagnosis. I know it's a diagnosis. Is it represented as a SNOMED code, an ICD-10 code? Is it in free text form? Can I get it to the nearest matching SNOMED code or ICD-10 code that I can then utilize as refined data that can feed our applications or our analytics? And I'll take an example in terms of outcomes that are relevant to our customers. So, when we produce quality measures, let's take an example of, say, HbA1c measurement for a cohort of patients with diabetes. We're looking at lab values that are coming in, and I want to go back to Anne's number, 247 different ways in which just HbA1cs are represented. In order to report out on that quality measure, I would have to understand those 247 different ways. But HEDIS has already prescribed the LOIN codes or the CPT codes or the SNOMED codes that are appropriate in that value set that I need to report back on. So my mission then becomes, okay, how do I take these 247 or maybe even more, depending upon how dirty that data is, and get it to as close to possible as to this value set so that my customers can report out on these quality measures. And a lot happens in kind of getting you from that raw data to making it reportable and codified so that it can actually be usable in the context of that quality measure. Brian, did you want to talk about how you roll up your sleeves and actually make that magic happen so that we can rely on you to optimize that process?
Absolutely. Happy to dive into the weeds a little bit on this one. So, and as you mentioned, those lab values are used for a lot of things, right? We're looking at the quality measure example where, it may be, is a patient's diabetes controlled. But as you think about even fulfilling that measure, by having inaccurate data, we're impacting both the patient who might get a call from care management saying, hey, you need to go take that A1C test, to the financial impact of actually not seeing that you actually met that measure and getting credit when that test was actually performed. And so all of that outcome is driven directly by the quality of that data. And so we start with this, as Mike was alluding on the slide that had the 6 different phases that were there, verifying the data. Is it an actual valid LOINC code is the first thing that we look at from that perspective. And I know Innovaccer was already running these data quality checks, and in our integration gives a little more comprehensive set of lab values, because we have all the historical values for LOINC. And what we found just with that one analysis on that one client is that 33% of the lab codes that they were providing were actually invalid. They weren't valid LOINC codes. And so you just think about that impact on the analysis in your dashboards that are going to be running, and that's huge. And so to get that data standardized, we've taken a very unique approach with that, in that we are leveraging a large language model to do that. And you can't just pull a large language model off the shelf and expect it to operate great. Unfortunately, that's not the world that we actually live in. And there was one of the items when you were querying on the problems that folks were seeing, and one of it was poor data for AI. And what we've done is actually, because we have a clinical team that is very knowledgeable in the lab domains, we've actually taken that expertise in the years of mappings that we've been doing, so literally millions of curated maps, to be able to train a model on what is the correct answer when you get those 246 different ways that something's actually coming in. And on top of that, we've then layered our set of synonyms that we use, as well as expertise in knowing the different components that make up a lab code. So for those of you not familiar with LOINC, it is the standard that gets used for labs. And there's everything from the component to the specimen to the time, was the person fasting or not, a whole series of attributes that you need to know in order to get to the accurate code. And so our clinical expertise has allowed us to build this model that, with this one data set, we saw an increase in the accuracy by 30%. And so it allows Innovaccer to plug that in and get that data more standardized, so that as you're doing that analytics, your dashboards are more accurate, in the kind of results downstream for both the patient as well as potentially the payer are a lot better because of that accuracy of the data. And Mike, you had mentioned the kind of completeness of the data as one of the items that's there. And what's been really fascinating for us is, there tends to be two siloed approaches to data. You have the claim data going through its kind of path, and tends to be fairly accurate, because if you want to get paid, you have to be using valid codes for that piece. But the clinical data kind of has its own path and its own flow that sometimes completes and sometimes doesn't. And what we've been able to do with our clinical knowledge of both the claim and the lab data is generate a map between those, which allows us to look at the completeness of the data. And so what Innovaccer is able to do now is look and say, hey, we've got this data, we're actually missing lab results that we should be receiving, that we could then use for these quality measures, and work with their clients to get that data kind of coming in. And through that exercise with a client, we found that there were over 50 million lab results that they were missing. And on average, about 10% of the labs are related to HEDIS. And so you figure that'd be 5 million additional rows that could be used in the analytics, closing those gaps in care that would happen as a part of it. And so that kind of marrying of that clinical data, for us, fulfills that completeness of the data, and makes sure that, it's accurate through that verification stage. It's the accuracy on mapping to the correct code through that normalization, and then completeness through that analytic piece with the marrying of that data. So that's really where we kind of focus, and we felt the partnership was amazing. You already had the framework of bringing in all these disparate sources. You already have a lot of the validation process in place, and then we're able to help with just a couple nuanced pieces, but that can be very impactful with that piece. So that's really how we view that piece, Shobha.
Yeah, absolutely. And, I know we mentioned this as one of the dimensions of measuring data quality, but I think even in the algorithm, as I familiarized myself with using the map manager, I love the transparency piece. I love the fact that I can see the confidence level at which something is auto mapped, whether it's at an equivalent level, a high level, or something that I need to manually intervene on and look at how the algorithm is thinking. I think since AI and, is such a hot topic these days, a lot of folks have talked about, that black box effect of an algorithm. You don't know how the algorithm is churning some of its results. But that's quite contrary to how you guys do it, because I love the fact that, within a threshold, I can go in and actually see the logic and see the transparency of why a certain concept was mapped to a certain code. So yeah, kudos to you guys. I think we can really use some of the thought process that's been put in order to optimize and streamline our workflow in terms of automatically mapping these. Excellent. Well, this is a complex problem, and I know both our organizations are well entrenched into solving similar aspects that come together for producing better results for our customers. Talk to us about how you think of scalability, because a lot of folks in this space think of the DIY approach. Get a few clinical informaticists, try and solve the problem themselves. It's a hard problem to solve. So talk to us about how Health Language is thinking about making these improvements scalable. Anne, could I turn it over to you?
Sure, thanks. So yeah, when we think about scalability, we really think about scalability and interoperability, openness. And I think, again, I'm going to go back to sort of fundamentally what is core to who we are. We believe that to make healthcare better, to make the quality of the data better, you need to have an open relationship to that data. And that starts within the value chain. Where do you get the greatest sense of purity of meaning? You get that at the point of care. And so even though when you think about the analytics, you may think like, well, why do I care about the synonym that the provider uses at the point of care? Well, when providers, like in med school, I'm not aware of a course that is given in coding, in ICD-10 and how to code ICD-10. And so when you think about the clinical term that a provider is using at the point of care that they're entering, behind the scenes, you're taking that synonym and you're saying, let me capture that, and how should I translate that into the standard code that's going to go on the claim? Well, there are people out there that do that. Health Language does that. There are other providers that do that in more of a black box. We're very open in that. Why is that important? Because that mapping might not always be right. So if you know what those synonyms are, if you know what those terms are, if you know what they link to from a standard perspective, you already have that knowledge from the beginning of the data value chain of what are the words that matter, what are the words that are used to create and to drive these terminologies, the ICD-10s that end up on a code, the labs that end up converting to LOINC. When you move along the data value chain, what do you want to do next? And that's where interoperability really comes into play, because now you've collected data from so many different sources, you've brought it together in one place, and now you want to be able to do something with it. But if you think about the fact that everybody's used a different language, potentially, a different translator in how they translate those synonyms into the codes, now you've got to normalize it. You've got to identify what are those. You've got to clean them, and then you've got to decode them. And I love this idea of like the decoder ring, because one of the things that we do at Health Language is we use that knowledge that we gain at the point of care, that clinical insight. How are clinicians describing these conditions, so that when they end up in your data, we're way more intelligent in our ability to build those maps, because they may end up in your data and the next client's data and the next client's data. And so what we've used by taking this position that we have in the value chain is that as a core advantage to what we do, to build those clinical maps, to embed them in our map manager solution that Shobha talked about, so that when you have a term that you don't recognize, that isn't normalized to a standard definition, that doesn't have that veracity or that trusted meaning that it's meant to have, We give you that tool, and we have the large language models that Brian mentioned working behind the scenes so that that normalization can happen automatically for you. And in some circumstances, there may be alerts where you need to make a choice, and we want to make sure that you pick the right map. But then you can, as you go through the value chain, sort of set it and forget it. So now in the final part of that data value chain, now you have ideas. Now you have things you want to do with that normalized data. You've built those maps. You have large language models working behind the scenes to constantly get better as new data comes in to make sure that it's translated to that standard. And now what do you want to do? Well, now I want to create some analytics around it. I want to group that data. But here's what's really important. What happens when one of those updates occurs that we talked about to ICD-10 or HCPCS or a LOINC, and that's built into your analytics? Well, what's beautiful about our solution is you can set it and forget it. You can automatically choose to allow those updates as they come in to propagate into your analytics, or you can create an alert. So you say, oh, when something changes in this foundational data that impacts what it is I'm trying to monitor as a particular analytic, it can encourage you to come in and take a look at that. And again, it's these set of tools that sit on top of that foundational terminology, that foundational system, that really try to benefit from all of those capabilities throughout the value chain that really help us to create that scale. Because you need that scale in order to do all of the exciting stuff that goes well and beyond the semantic richness of the data. Mike, do you want to talk a little bit about all the other aspects and work that you need to do with the data beyond that veracity piece?
Sure, sure, and I love the way you put that. You know, you get the foundation of, you know, your guys' knowledge and get a good terminology service, but then how do we scale it? You know, and we have a number of customers. We have nearly 100 customers, and some of them have 100 analysts, some of them have 1,000 analysts. We have a couple customers have tens of thousands of analysts. How now do you get that scale and that knowledge into all these other different departments? And it's like Shobha said, it's not a small task. And what we use kind of to define that is a data management and governance framework. And putting that in place is a very complex thing in an enterprise, but it's a requisite if you're going to extend this knowledge that you all have created into all the useful departments, whether it's in the IT departments or the clinical departments on that. So I think we've talked a lot about, you know, the data quality management, but one area that is often misunderstood and can get fairly expensive is common reference data. Whether it is those link codes you're talking about, you need to have a consistent version of that. It needs to be managed. There should be one, and there should be a master. I know I've worked in organizations where something as simple as zip codes, we had replicated within our environment 40 different times, and few of them were on the same version. Now that, you know, that's maybe not the most horrific thing, but when you get into some of the clinical coding, I don't think there's that error, you know, that error tolerance is allowable. So this area of getting your reference data and reference tables shareable and usable amongst your entire analytic environment. And then related to that is the master data management. And I mentioned this earlier a little bit, you know, master data means we're all working off the same sheet of music, and we're not curating our own, we're not creating our own masters. I know I joked, I worked at one company and we had 20 data warehouses. 4 of them called themselves the enterprise data warehouse. They had the exact same name, and none of them were actually the enterprise data. And then the last point, I'll put metadata and data lineage together. This is a super critical path, because if you're going to get that trust of the physicians and the analytic community, you need to be able to show that data pipeline, how the data has matured and curated during its journey, you know, in that supply chain. And so you have to be able to go back and say, where did the data originate? What were the mappings that were done? What rules, what AI, what machine learning algorithms were taken to convert and manipulate that data? And then where was it consumed? many times people don't know that a data set, where it gets used. You ought to be able to answer that questions backwards and forwards on the data lineage thing. A lot of that, again, is going back to the veracity word and gaining trust in the data that we're using. I will stop there on that one. And
No, these are certainly key pillars. I know we've only touched on maybe one or two of them in our conversation today, but this is really a mission that brings both of our organizations together. We are committed, if you think about the beginning of the presentation, we are committed to making healthcare better for Katie Harrington. And we are doing it in accomplishing that mission by solving a small but critical piece of the puzzle by improving data quality, making sure that when we bring data, Katie's data together in front of a provider, we can present a picture that's cohesive, comprehensive, and allows her provider to make the best healthcare decisions for her. I know we've talked about with our panelists today how we're working on this mission within our organizations, but there's a lot that's going on for anyone who's interested in this space. There's a lot that's happening in the national arena. And it's certainly, as an informaticist for 2 decades now, I've certainly seen the space, change a lot in terms of the interoperability between systems, in terms of regulations and policies that have enabled that, starting from meaningful use to some of the developments that we see between payers and provider systems today. Brian, you've been in the thick of things with me. Tell me a bit more about your perception and your journey on this.
Yeah, and I'll start out saying I had hair back when meaningful use started, okay? But and maybe I lost it because of it. I don't know. But I did kind of work a lot with EHRs as they were trying to adopt meaningful use and being able to get, the LOINCs, the SNOMEDs, the ICD-10 kind of all captured and within their data that could then be used as we look at that buzzword of interoperability and are we there yet? And that was a great start. It really set a solid foundation, and we started to see some of the data be usable, which was really kind of night and day. I came from a telecom background, and when I stepped into healthcare, I thought they were pranking me on the state of this data. And I'm like, no, that can't be how it works. And it ended up, being able to kind of get that standardization. And as we now look at like the 21st Century Cures Act, and in particular, as we're looking at like the US CDI, instead of it being just a couple components that we're working on of the drugs or the labs, we're getting a lot larger set of data that we're standardizing, and that standardization is really what's going to power, as one of the items in the poor data for AI and being able to let that technology help us. I really do feel with the 21st Century Cures Act and the adoption of FHIR that we're moving towards a place where the data a lot more data elements will be trustworthy, right? They're coming out of this source, that veracity that you talked about, Mike, like we'll have more of that faith in the data. We'll still always QA it, but we'll have more faith in that data as it travels from place to place. And so I feel like we're on a journey the next couple of years with kind of the more adoption of FHIR and some of the regulation and the HTI-1 for kind of the measurement of that and complying will really help us get more confidence and more data that's usable across this enterprise or across this continuum. And Mike, do you want to talk about a little bit more on like the TEFCA side of things and some of how that's also helping improve the quality as we go?
Yeah, and since you're talking about the olden days, I'm going to go back even further, I guess. Right. There was a point in this country, and this will make sense in a minute, but there was a point in this country where people didn't wear seatbelts in their cars. Right now, everybody wears seatbelts. But if you maybe you don't all remember because maybe no one's been around that long as I have. But the slogan was, not only is it a law, it's a good idea. And if you look at these standards here and these regulations that are coming out, they are good ideas in data management. The TEFCA rulings, when I went through that TEFCA, the TEFCA rules, I go, these are things I've standardized at enterprises I've worked in forever. Now someone's written it down and been thoughtful enough to apply it to how it applies into our clinical space and our claims management space and the data in our healthcare industry. But these are good ideas. And like you mentioned, Brian, they're all at different levels of maturity. But, you know, I don't think my father ever wore a seatbelt, but eventually all his children do. So I think it's the same thing here. Maybe it'll be our children adopting the principles in TEFCA or being able to create an application out of FHIR. Everything, in my opinion, I think is summarizing what you're saying too, it's heading in the right direction. And we just need to find a way to get it implemented and scaled into the healthcare industry.
No, certainly. I think it's obvious that this is just a start of a collaboration, and so much of the conversation today, at least I've gained an appreciation for the breadth and the depth of the problem. It makes us feel really great at Innovesa that we've joined hands with Health Language because, you know, as you can see, folks are equally passionate about chipping at the problem, and we're excited to have you here in working on this together. Our teams have come together and in not just the technical aspects, but also in producing some content assets that you can go back to and get to know more about this collaboration. So you can use that QR code, get to know more about how our two organizations are coming together to solve this problem that we talked about. This is certainly a journey, and we hope to come back to you with more conversation on outcomes that have been achieved and results of this collaboration. So stay tuned, and thank you for being a wonderful audience. I'll take a couple of questions since we have a few minutes from what has been sent over the chat. Feel free to send any more if you have questions. So there's an interesting one that came through talking about classifying or analyzing medical images, and if that's on the roadmap, and anything that Health Language is doing in terms of image classification.
Yes, actually, we didn't talk a lot about this today, but we have a solution specifically within the risk adjustment space. And back to sort of that beginning and the importance of point of care, one of the things that we do as a first step is something that's called chart organization. And so we look at the entirety of the medical record as it's OCR'd, and we go through essentially a number of we have I think there's 6 metadata models that essentially work against the entirety of that chart to organize it, to say this is an encounter, this is a lab, this is you know, a radiology report. And so we are indeed within that product and capability working at creating that organization, using that metadata to then be able to inventory a chart. The reason for that is then when you want to figure out what is the data that's important, a chart is, you know, it could be 500 pages of a lot of different kinds of records. And so that step of chart organization enables us to really hone in on where do we want to go, what is the unstructured data in many cases we want to look at, and then we're ensured that we're going to the right place in the chart to find that unstructured data that we may need to translate.
Yeah, certainly need to talk to you more about that. So more to come. We do OCR converted to unstructured text that can then be used for our analytics as well as for our applications. So we are able to make sense of the image, convert it into unstructured text that can then be parsed, and we look for clinical concepts that are of interest, whether it be for risk adjustments. So to take an example, if we were doing suspect coding and we go back to that ejection fraction example for Katie Harrington, say it came in as a lab result that was in an OCR, we would be able to convert that into text and then utilize that as a piece of evidence that we could use in order to infer heart failure. But would love to understand more and about how we could leverage some of that chart organization capability and add that additional context to, what kind of document this is that would help us utilize that better for our downstream applications. So certainly look forward to talking to you on that. Another question on, do you consider cultural and resource variations that can be drivers for different data inputs? And here's an example: critical access hospitals or CARs are going to have different languages than big academic medical centers. Thoughts on that, Mike?
Boy, I was hoping you were going to ask Ann or Brian on that one. That's a hard
Any of
question.
you.
I can actually help on part of that, Mike. When Ann had mentioned we help at the point of care, and part of that is, in this case, what we've noticed kind of feedback wise is not even, well, you could call it cultural, but regional differences. And I'll give you a quick example. When we think about diabetes, we call it diabetes, but we actually had a number of facilities that are in the South that call it sugar disease, right? And so for us,
Wow.
what we do is we make sure that we have those synonyms that is the way that they speak for that particular disease, and whether it's a regional item or a cultural item, as we get that feedback, that there's a search going on that isn't maybe necessarily getting the results. So we constantly take that feedback and are enhancing it so that no matter who the user is, they can speak their language in their context and get back the appropriate results. So that's how we've approached that one.
I agree with you, Brian. I think of this as kind of the next, level of semantic interoperability, where it's taking into account a bit more context than just the clinical intention. You gave the example of diabetes as being called sugar disease. I've heard of diuretics being called the water pill. And so just being able to understand, the language that not just providers, but also patients and other end users of putting in data into healthcare systems are using, and being able to get that into a codified concept. If your algorithm is able to take into account that additional context, the additional ways in which that clinical concept can be represented, I think that's really powerful. Any other thoughts from any of our speakers on this? Excellent. I think we are at time, and really appreciate the conversation. It's been exciting, and I really appreciate the audience chiming in and giving us things to think about along the way, as well as your questions. Thank you. You've been a wonderful audience. Look forward to more conversations in the future.
Thank
Thank
you
for leading us through this,
for a
Shobha.
great job.
Absolutely. Thank you all.